Dr. Warne is Associate Dean for Diversity, Equity, and Inclusion at the School of Medicine and Health Sciences at the University of North Dakota, and also directs both the Indians into Medicine program there and their MPH program. His research examines the impacts of historical trauma and adverse childhood experiences, or ACEs, on health. And in his talk today, Don will examine historical and cultural factors that have had an impact on the health of American Indian families and identify potential solutions towards achieving greater health equity. With that, I'm going to turn it over to Don so we have plenty of time to hear from him. And thank you, Don.
Great,
thank you.
How pilami ayelo mitaku yepi. Hello, thank you, and welcome to all my relations here today. I'm very happy and honored to be a part of these discussions, and I'm so happy to see academic institutions focusing on the whole idea of promoting equity and making sure that all populations can live in a healthy way. So as was mentioned, I'll talk about the impact of unresolved trauma on American Indian health equity, and I'll give you a little bit of my own background as well. I'm Oglala Lakota, originally from a small town called Kyle, South Dakota. But my people are known as the Oyate, and you may have heard of Sioux Indians, right? We've all heard that term, Sioux Indian, S-I-O-U-X. We never called ourselves Sioux Indians, actually. We called ourselves the Oyate. And the Lakota were further west, in what is now western South Dakota and North Dakota. The Dakota were to the east, including the western part of what is now Minnesota, and the Nakota were to the south. So the reason it was called the Dakota Territory, and the reason it's North Dakota, is that colonization came from the east. So they encountered the Dakotas. So that's why it's North Dakota. If colonization had come from the west, it'd be North Lakota. So it'd be UNL instead of UND. That's really the reason. So you've heard the term Sioux Indian before, right? Sioux is actually a shortening of an Ojibwe word that means snake or enemy. It's snake in the grass is actually what it means. And the reason we were called this is the French settlers did not like us. So they used that term to call us snakes in the grass or enemies. So anytime you use the word Sioux Indian, you're actually saying snake, you're saying enemy. So it's actually a derogatory, pejorative term. So I don't call myself Sioux Indian, so I'm Lakota, that's who I am. And again, we did have our people also in what is now western Minnesota. That's where the Dakota people were located. So the Dakotas still have 4 small reservations in Minnesota: Upper Sioux, Lower Sioux, Prairie Island, and Shakopee. And those are relatively small communities. And I'll talk a little bit more about this in terms of history and how that leads to unresolved trauma. But there was a war in 1862 called the Dakota War, which pushed most of the Dakotas now west of what is known as the Red River of the North. And that's the river that separates North Dakota and Minnesota. So where I work currently is in Grand Forks, North Dakota. So Grand Forks is called Grand Forks because it's a confluence of 2 rivers, the Red River heading west, the Red Lake River heading west and the Red River heading north. So where those 2 rivers meet is actually in many ways a sacred place. You could at one point in time take a canoe from Red Lake all the way to Lake Winnipeg. And this whole region, the Red River Valley, was a gathering point for the Oyate, Lakota, Dakota, and Nakota. So where I work now really is my people's homeland. And I get asked all the time, why is it that you work in North Dakota? It's a cold place, it's not a very populous place, but I'm there because it's my homeland. It's where my people are from. So I'm sure you've heard the word Minnesota, right? How many people know what Minnesota means? Okay, Derek, actually my friend over there, he knows what Minnesota means. So Minnesota actually comes from 2 Dakota words. Mani is water. So you may have heard of, during the Dakota Access Pipeline issues, Mani Wichoni, water is sacred, or water is life. So Mani is water, and Shota means like smoky or cloudy. So Shota, a Mani Shota, is literally when the smoke rises off the water. So this is a Mani Shota. So that whole region with all of the lakes and other types of waterways was known as the land of the Mani Shota, or short to Minnesota, right? That's what we call it now. So that's Minnesota. So you probably also heard the word Minneapolis, right? So that's actually from 2 words as well, but in this case it's Dakota Greek, so Dakota Mani, And Greek polis means city, right? So it's water city in Dakota Greek. So every time you say Minneapolis, pat yourself on the back, you're being bilingual in Dakota Greek. So that's the area where I work. And where I'm from originally is Kyle, South Dakota, on the Pine Ridge Reservation. And I always like to ask, how many people have been to Kyle, South Dakota? Wow. That's like 6 more than usual. That's actually very, you'll have to let me know how it is that you wound up actually visiting Kyle, South Dakota. The original name is Prejuta Haka, which means medicine root. And it's an area where we still have a lot of our traditional healers and medicine men. And it's also an area where we still collect a lot of our traditional herbal medicines. There's an area between Kyle and Allen, South Dakota called Yellow Bear Canyon. And we still harvest a lot of our healing herbs and roots from this region. But it's now called Kyle, South Dakota. It's where I'm from, and it's a very small town. There's a 3-way stop sign. That's about as big as it is. And we have a lot of poverty where I'm from, but it's very rich culturally. We still have a lot of strength in our connection to tradition. So this is a picture of the Little Wound School. Little Wound named after Chief Little Wound, who was one of my ancestors. And there's kindergarten through high school at this school. And it serves kind of the greater Kyle region. I'd like to say the greater Kyle metropolitan area. One of our big challenges, though, is that less than half the kids who start kindergarten actually graduate from high school. So our dropout rates are over 50%. And this is true in many of our reservation communities. So if we have more than half of our kids not even finishing high school, then the question is, where is the next generation of doctors going to come from? The next generation of nurses or public health professionals or teachers or attorneys or business people. So we have to recognize that educational outcomes have a tremendous impact on public health, and we know that in public health. And when we develop educational programs to improve outcomes for grade school, middle school, and high school, in many ways that is a public health intervention. So we have all kinds of challenges related to poverty and challenges related to education. It's also a food desert. Now this is the cafe in Kyle. I was here just a couple months ago, and the cafe has closed down. So hopefully something will reopen that provides healthier foods. But I think what they learned here is that you can bread and deep fry just about anything and serve it for lunch. So the foods that are available are things that can be stored for long periods of time. And the reason it's a food desert is that there's no local access to a supermarket. The closest supermarket to Kyle is in Rapid City, South Dakota, and that's 90 miles away. So imagine doing a 180-mile round trip every time you wanted to go to a supermarket. Then add on top of that poverty, limited transportation, bad weather. So what would you do? How do you actually get access to healthy food under those circumstances? So right across the street from the cafe is the gas station. And the gas station doubles as a grocery store. So they have a convenience market there. And you can imagine the type of food that's available, right? It's things that are in cans or bags or frozen. There is a small section for fruits and vegetables. We'll put fruits and vegetables in terms of fresh, we'll put that into quotes. Not a lot of healthy choices. And in public health, in addition to the idea of a food desert, there's also the concept of a poverty tax. And it's not a real tax per se where the government takes a percentage of money, but people who live in these communities pay more money for fruits and vegetables than people who live in a city or a suburb because of the cost of transporting perishable goods to these remote communities. So you could want to eat healthy foods, but have limited access, and it costs more money. So we're doing all kinds of things from a policy perspective and from our structural perspective to keep people sick. So what's the outcome if we don't have access to healthy food choices? The schools are impoverished, so most of the kids are depending on the schools for breakfast and lunch, and they don't get healthy food in those settings either. Did a site visit at one of the schools, not in my home community, but another reservation. And the most popular breakfast item was the giant cinnamon rolls with the white caked on sugar. And kids would eat 2 or 3 at a time because they're hungry. And this is also the population of children in the US that has the highest risk for type 2 diabetes in the world. So we keep making things worse based on where we invest our resources. And we promote inequity based on current policies. So one of the outcomes of that is just terrible health disparities. There's a picture of one of my uncles, and he has a leg amputation. Why is his leg amputated? Poorly controlled diabetes. Isn't it remarkable that we just know that now? Leg amputation, diabetes. If you asked that question 40 years ago, people might say, oh, it must be a combat veteran, right? But now diabetes has become so rampant across multiple populations that we're accustomed to seeing the outcomes of poorly controlled diabetes, like amputations, like heart attacks, like dialysis, right? Kidney failure. In many of our reservations, the newest, nicest building on the reservation is the dialysis center. How obscene is that? You know, we're investing once we have organ failure or significant complications of the disease. So there's another program in my community where they will build a ramp for people who are in a wheelchair. So you can see there's a wooden ramp so he can get into his home. And that's wonderful. If you're in a wheelchair and need to get into your house, at least there are services that will build you a ramp. But wouldn't it make more sense to invest in healthy food in the first place? We don't do that. So once you have diabetes and your leg is cut off, then we'll invest in your needs, but not before that. So what are we telling our children? We're telling them that we're not going to invest in their health. The only time we will invest in their health is when they have an amputation, we'll build them a ramp. Or if you have kidney failure, guess what? You automatically get Medicare, right? So kidney failure is one of the automatic qualifiers for Medicare. So we invest in the challenges after they've occurred. We don't invest nearly enough in primary prevention and addressing the problems on the front end. So where I'm from, there's a lot of rich history and culture, but we never had a written language. So we don't have written textbooks that we can draw upon for understanding our history. But we do understand history and life lessons through stories. And there's a story of three sisters walking along a river. And as they're walking along the river, they see babies and young children in the water struggling to stay afloat. So the first sister jumps in and says, this is an emergency, it's a crisis. We need to get the babies out of the water right now. You probably all know people like this, right? The second sister thinks about that and says, no, we need to teach the babies how to swim so they can survive while they are in the water. And the third sister keeps walking upstream. And the other two get angry with her and say, where are you going? Why aren't you helping us? And she says, I'm going to find out who's putting these babies in the water, and I'm going to stop them. That's public health. That's literally working further upstream. So when I look at public health, I recognize that it's consistent with traditional medicine principles from a cultural perspective, that we should be looking at things in a much more comprehensive way. So do we need that first sister who's taking care of the crisis? Well, absolutely. We need emergency room physicians, we need ICU physicians, we need hospitalists. Do we need that second sister who can help with chronic disease management, outpatient care, primary care? Of course we do. But we also need that third sister walking upstream. We need effort put into preventing the issues from occurring in the first place. So I put a lot of time thinking about the overlap of modern health inequities and traditional cultural approaches. And when I think about our challenges, I also have to recognize that we have a lot of diversity in American Indian populations. This is a map of the Indian Health Service areas. For those who don't know, Indian Health Service is the federal agency that provides health services to American Indians and Alaska Natives. It's divided into 12 areas or regions. And where I'm from in the Great Plains, we tend to have some of the worst health outcomes in the nation. Actually, the average age at death for men from Pine Ridge, my home reservation, is now down to 48, average age of death. For women, it's a little bit better at 54. So 48 years for men from my community. I'm 52, so I guess I've reached my longevity, right? It's all gravy from here, right? But it shouldn't be that way. And unfortunately, we tend to see some of the worst health outcomes in the northern plains, the Billings area of IHS, Great Plains, and Bemidji areas. And for those who are from Alaska, I apologize. I know Alaska is not off the coast of California, but this is the best map that I have. So this is a map showing the states that have at least 3% American Indian or Alaska Native population. So this is population by concentration in each state. And there's now only 7 states that have at least 3% American Indian or Alaska Native. So Alaska, Montana, North Dakota, South Dakota, Arizona, New Mexico, and Oklahoma. So we see huge just sectors of the United States in which there's very few American Indians. And especially the East Coast, very few American Indians left. Now, why is that? Is that because historically Indians didn't like the East Coast? Too much traffic? Well, there's a reason for this, for the pattern of population in the US, and it has a direct impact on equity. So right now, we have 35 states that have federally recognized tribes. So there's 15 states that do not. So what that means is that of those 15 states, 30% of the US Senate has no tribes in their constituencies. Do they care about our issues? If you're from a state that doesn't have a tribe, would you advocate for IHS? Why would you? Is that going to get you any votes? So we have a lot of built-in inequity because of our distribution of population. And when we look at this map, we have to recognize that the only reason we're concentrated in the West is that colonization started in the East. If colonization had come from the other direction, the map would be reversed. So this is a part of the discussion that is difficult, thinking about the historical context of American Indian population and what's happened over time. And what does that really mean for long-term and intergenerational health impact? Well, if we look at our 48 states, of course, at the time of contact, the entire region was Indian country. So when I see this map, I like to say, let's talk about Indian country, right? The entirety of the United States is indigenous, but of course we've seen tremendous changes over time. The 13 colonies were terrible for the northeastern tribes. So there was a time when the population was filled with indigenous peoples in what is now the northeastern United States. But through colonization, through warfare, and in many cases the intentional spread of disease, many of those populations were wiped out. You may have heard of Amherst, Massachusetts, and Amherst College, named after Lord Jeffrey Amherst, who was a colonial governor. And I'm sure some of you know this story, but Amherst is very famous. He is the one who ordered the distribution of blankets from a smallpox hospital to the northeastern tribes with the purpose of killing them. So our first documented case of bioterrorism is our own colonial government. We don't frame it that way. It's very uncomfortable to think about and to talk about, but that is a part of United States history. First documented case of widespread bioterrorism, the intentional spread of smallpox to kill indigenous peoples. And the outcome is there's hardly anyone left in the Northeast because of that effort. So you can actually Google Amherst and smallpox. I like how the word Google is a verb, right? And you'll find the letters that he wrote in his own pen. And I know it's very hard to read here, but it is translated. And this is what he said. You will do well to try to inoculate the Indians by means of blankets, as well as to try every other method that can serve to extirpate or get rid of this execrable or horrible race. Extirpate this execrable race. I should be very glad your scheme for hunting them down by dogs could take effect. Yeah, you can find that if you look for it. So one of our challenges when we're trying to promote equity is that we also need to understand the truth. And I don't tell these stories and talk about these things to make anyone feel bad. That's not the point. That's not the intent. The reason we have to understand these things is that if we are ever going to get to equity, we have to walk through truth, even when it's unpleasant, even when it makes us uncomfortable, because it is the truth. This is the truth of our history, and if we're going to get to the truth of the solutions, we better have a common understanding of the reality that our people face. So this is also, in many ways, kind of a slap in the face to indigenous peoples. We honor this bioterrorist by naming a city after him, naming a university after him, Amherst College. He was a mass murderer. There's no two ways about that. intentionally killed many, many thousands of indigenous peoples. I wish that was taught in our history books. It's not taught, I think, because it paints us in a bad light, right? We look bad as a nation when we have this as part of our history. But we need to be honest. We need to tell the truth, even when it's uncomfortable. So in the Southeast, a lot of the tribes are not there anymore either. And that wasn't due primarily to things like smallpox. You may have heard of the Trail of Tears. That's actually named after what's called the Indian Removal Act of 1930. So there was a law, Indian Removal Act, which was originally advocated for by Thomas Jefferson, is to forcibly remove tribes from the Southeast to somewhere in the middle of the country. So the Indian Removal Act, or Trail of Tears, led to the removal of tribes from their homelands in the Southeast to what is now Oklahoma. So of the 40 or so tribes in Oklahoma, only 4 of them are from Oklahoma. The rest of them were removed from another location. And in that process, some of the tribal members refused to leave. So they stayed in their homelands while some did get removed. So that's why we have these dynamics now where we have Cherokees in North Carolina and Cherokees in Oklahoma. Seminoles in Florida, Seminoles in Oklahoma. Choctaws in Mississippi, Choctaws in Oklahoma. You get the point. So Oklahoma was set aside as Indian territory. That was to be where the removed tribes could then stake out claims and create their own reservations. So there was a date set aside in the early 1830s for this process to occur. So for those who are college sports fans, what's the mascot for University of Oklahoma? Sooners. How many people know what a Sooner is? A handful of people do. Very good. Most people don't. So a Sooner actually reflects this time frame. There was the date set aside for the tribes to claim the land, and the non-Indians who got there sooner took it. So a Sooner is a land thief. It probably wouldn't engender as much school pride to say the University of Oklahoma land thieves, but that's what a Sooner is. So that's why before their football games, they'll take out a covered wagon onto the football field, Sooner Schooner, Sooner pride, Sooner culture. But actually what that is the thieves of the land. Does land ownership in modern America correlate with wealth or poverty? Absolutely. So when we think about this is actually part of the roots of ongoing poverty, was that our land was stolen, actually. Isn't that remarkable? And think about all of the wealth that's been generated out of Oklahoma just from oil alone. That was stolen. It's documented, it's well known, well understood, but not taught in our history books for some reason, right? We don't like to acknowledge the things that make us look bad as a nation. But there are real people who were impacted in a very real and meaningful way, and we see the ongoing intergenerational challenges. The discovery of gold was not good for the California tribes. During this time frame, after 1849 with the discovery of gold and going on over the next 20 years or so, there were a lot of Indian wars. You may have heard of that term before. And there was a time frame where it was actually legal to kill American Indians for a bounty. You may or may not have known that occurred in California. It also occurred in Minnesota. So the Dakota War of 1862 is what pushed the Dakotas west from their homelands in Minnesota to what is now North Dakota and South Dakota. So during this time frame, it was legal to kill American Indians. You can see here, Sioux Scalp, $25. So you could trade in a Sioux Scalp for a $25 bounty. That was a lot of money in those days. So that's why even in museums, you'll see scalps of American Indians that were from this time frame. Perfectly legal to do in U.S. history. So I used to show this image, and a few years ago, someone sent me a newspaper clipping from the following year, 1863, from Winona, Minnesota. It says, the state reward for dead Indians has been increased to $200 for every redskin sent to purgatory. This sum is more than the dead bodies of all the Indians east of the Red River are worth. Yeah. We probably don't know much about this in our history books, right? And again, I don't tell this story to make people feel bad. That's not the point. But we need to get to a point in this country where we acknowledge the truth. This is part of our truth as a nation. And it's why the American Indian population is spread so thin, and why there are entire sections of the US in which there are no American Indians left. There are policy bases for this, and incredible inequities that allowed for this dynamic to occur. So this is a map from the US Census website, and it shows the concentration of American Indian population by county. So you can see there's entire sections of the US in which there are essentially no American Indians left. But again, concentrated in those 7 states with Alaska, Montana, North Dakota, South Dakota, Arizona, New Mexico, and Oklahoma. But that's why there's also so many American Indians in Oklahoma, because of removal. And the reason that we're concentrated in the West is because the eastern tribes absorbed the brunt of colonization. So that's why our populations are distributed in the manner that they are. So when we look at the numbers, we estimate that in North America and South America, there were probably about 20 million indigenous peoples living in the Americas. And of that number, probably about 5 million living in what is now the United States at 1492. By 1900, there were less than 200,000 American Indians left. From over 5 million to less than 200,000. It was almost a complete genocide. Many of the tribes were completely wiped out. So we have to acknowledge that this is a tremendous impact. In many ways, this is the American Holocaust. Sometimes people get uncomfortable talking about it in these terms, but that's exactly what this is. Our people were almost completely eliminated from existence. So the good news is, by the 2010 census, there were 5.2 million self-identified American Indians and Alaska Natives. But when you have this pattern of loss of life, loss of population, loss of land, loss of culture, loss of resources, does it have a health impact? And can that health impact be passed on from one generation to the next? So when we think about unresolved trauma in American Indian populations, we have to recognize that part of that unresolved trauma is the long-term impacts of genocide and historical trauma. So there are a lot of people who've been studying historical trauma in various populations, and what we see is that when some populations suffer significant traumas, like what I'm describing here, we do see intergenerational impact on health status in future generations. So how do we draw that line between history and current health disparities? So this is from a publication I did several years ago with one of my colleagues in North Dakota. And we have to recognize that there's multiple components to this. We also have a unique history with boarding schools. I'm sure many of you are familiar with the idea of boarding schools in the US. And they were called residential schools in Canada. And what would happen during the boarding school era is that children were taken from their homes on reservations, and in some cases put into boarding schools many thousands of miles away. My own mother is a survivor of boarding schools. She's now 80 years old, but still doesn't like to talk about her experiences in boarding schools. And we have really a lot of documented examples of terrible things that did occur at these boarding schools. Another challenge that we face, just looking along this lifeline, high rates of stress during pregnancy. We unfortunately have a lot of unplanned pregnancies, a lot of young people who are self-medicating unresolved trauma and wind up getting pregnant, and then those children are at great risk when there's a great deal of stress during pregnancy. So in terms of boarding schools, this is a picture of the Carlisle Indian School in Carlisle, Pennsylvania. And each of these boarding schools has a large graveyard right next to it. And we know that we have a lot of excess death of children who attended boarding schools. And we don't know why. We know that there were outbreaks of things like tuberculosis, but that doesn't answer the question as to why did we have such an extent of excess death. We probably will never know why so many American Indian children died when they were at boarding school. But I look at this, each of those headstones represents an American Indian child between age 6 and 12, And of course, it's history. This happened in the previous century, in the 1900s. But when I look at this, someone loved each one of those children as much as I love mine, as much as you love yours. And they were taken away. Carlisle, Pennsylvania, died 1,000 miles from home before we had good transportation. So they just stay there. They're just buried in Pennsylvania, not in their homelands. I was able to take some pictures of some of the headstones. There's an Alvin who's Lakota, they say Sioux here, died in 1881. I had an uncle, Alvin. So I think about these things, and one of the other heartbreaking components of this is they have a whole row of headstones that says unknown. They don't even know the name of the child who died. Just unknown, lost to history. A soul just lost to history. Not even acknowledged, not even remembered. Does that make some of us feel bad? Does it cause anger? Does it cause depression? Is there a biopsychosocial response when we understand these types of components of our history? And the fact that the modern society doesn't even care enough to talk about it in our history books. So not only are we suffering through the traumas, the whole history is not even acknowledged by modern society. That's harmful, to just ignore and not acknowledge some of these challenges. So how does this pass from one generation to the next? And there's been some fascinating studies that are looking at potential reasons why some of the negative health consequences can occur from one generation to the next. And I'm sure many of you are familiar with epigenetics. And what we find is that when people live under very stressful circumstances, if there's toxic stress, that can actually have an impact on gene expression. It changes our DNA when there's toxic stress. So we see different patterns like methylation of some of the DNA, or where the DNA divides during meiosis and mitosis. There's the telomere where we see division of the DNA. So the telomere, as we get older, shortens. And what we see, people who are living under toxic, stressful conditions, it shortens the telomere. And that might explain some premature aging related to stress. So this all has to be worked out from a research perspective, but I really believe that epigenetics will provide a scientific platform for us to better understand historical trauma, how it gets passed from one generation to the next. There's been some really good studies in recent years looking at Holocaust survivors from Nazi Germany. And the descendants of Holocaust survivors have worse health status than matched controls who are not direct descendants of the Holocaust. So there's something happening in subsequent generations based on these types of outcomes. So that's one stressor, right? This historical trauma and related to boarding schools. There's other types of stressors that are really prevalent in impoverished populations related to poor nutrition. Now, we haven't identified all of the mechanisms yet, but we do know there's an epigenetic impact of poor nutrition that does occur. And the WIC programs, the Women, Infants, and Children, I'm sure many of you are familiar with that. It's through the USDA. It's a food program for impoverished moms and babies. And when I was working as a full-time primary care provider many years ago, the WIC program was basically a baby formula distribution program. They're just basically handing out baby formula. They've done a much better job in recent years to promote breastfeeding. And we know that as a population, formula-fed babies grow up to have higher rates of diabetes than breastfed babies. And it makes sense because breast milk is healthy, it's natural, it's what our Creator gave us to sustain our children. And the whole idea of baby formula is really interesting, isn't it? Does that sound appealing to anyone? Come on over, we'll have a glass of formula. It's called formula for a reason, right? There's chemicals in it, basically. So unfortunately, because of high rates of poverty, we have entire generations of American Indians who have higher percentages of formula feeding because of WIC. That's a policy-based intervention that led to higher rates of baby formula feeding for entire generations of Indigenous peoples here in the US. So how many people have heard of the Commodity Food Program out of the USA? Quite a few, good. Within what's called the Commodity Food Program, there's what's called the Food Distribution Program on Indian Reservations, FDPIR. So that's where commodity cheese comes from, government cheese, literally is from this. And I grew up eating commodity foods, so there was sugar, flour. It used to be lard that they would distribute, then they changed it to vegetable shortening, which is probably worse anyway. Then they also had grape juice, but I think it was just sugar water with purple food coloring. But I just remember as a kid, everyone had that Kool-Aid smile, the stain, the purple stain on their face from drinking Kool-Aid or the commodity grape juice. When we think about those foods, they're just incredibly unhealthy. And when we think about traditional foods, like right now, if you go to a powwow or you go to an event, what's a traditional American Indian food that's always served? Fry bread. Did we ever fry dough historically? No. So fry bread is not a traditional American Indian food. It's actually people doing the best that they can with their commodities. So the roots of fry bread are not cultural. The roots of fry bread are in the USDA. So when people say they want to say it's traditional, I say that fine, it's traditional USDA food, it's not traditional American Indian food. And you can see the elder, this picture on the right, she's using commodity flour and commodity shortening to make fry bread. But now it's been acculturated. So every time I go home for a ceremony or for a feast, there's an expectation that there will be fry bread. Why? Because it's traditional. Well, no, it's not. So part of our truth as tribes, as community leaders, we have to acknowledge that we're participating in colonization now. We've taken it over, we've owned it. That's ours. No, it doesn't have to be and it shouldn't be. I really believe there's epigenetic impact of toxic food. When we look at corn syrup and probably the biggest false advertisement in nutritional history is the whole idea of enriched flour. There's nothing enriched about it, right? It's all the nutrients taken out and all that's left behind is the starch. And that's how we make our fry bread. This is a picture of some of the commodity foods. They had these kind of Spam-like meat products in a can. I'm not sure exactly what that was. Powdered eggs, powdered milk, grape juice. On the right here, this is a big container of pure corn syrup. Now, for those of you who know nutrition, corn syrup is basically a toxin. And if you look on the label, it says, use in your baby formula. It says, use on your pancakes. And we wonder why we have such high rates of diabetes. People always seem surprised when I show these pictures, but this is true. This is what we grew up with, This was normalized in American Indian populations. And we're seeing the health inequities today, right? So these are remarkable pieces of history for us. I'm sure many of you have heard of adverse childhood experiences, the ACE study, and we know that the more adversity someone experiences in childhood, the worse their health status is as adults. And we know that when we see adversity in childhood, it can create disruptions in neurological development, it can have impact on behavior and social development, and then ultimately high-risk health behaviors and early death. And some of the outcomes of adverse childhood experiences include higher rates of obesity, diabetes, depression, suicide, even higher rates of sexually transmitted infections, higher rates of health risk behaviors like smoking and addiction, and then life potential, lower graduation rates, lower employment. So when I look at the outcome of adverse childhood experiences, it looks like the exact same list of American Indian health and social disparities. There's something linking together unresolved trauma and the health inequities that we see today. So does the trauma end when we turn 18? So we got through the ACE time frame, and now we're adults. Well, we have adverse adulthood experiences as well. Not as well described, I think, in the literature, but when we have toxic stress, ongoing marginalization, and quite frankly, in many of our communities, a lot of racism that American Indians still face, those toxic, stressful circumstances are not good for our health. And then the other question is, where are the traditional parenting skills built in? When you have entire generations of future parents taken to boarding school, what have they learned about parenting? When I was growing up, my uncles who are medicine men and traditional healers, they would tell us about the old ways of parenting. And it wasn't the idea of a nuclear family. And it's an odd term too, nuclear family. That's what we think about. But in the old way, it was the responsibility of one generation to raise the next generation. So aunts and uncles participated in raising the nieces and nephews. So I would be just as responsible for my nephew as I am for my son. And what a healthy way to raise families, that social support that's built in. We don't focus on that. Even when we look at access to health information, you have to be a mother or a father. Aunt and uncle, you don't count. Or when I have a student who needs to go to a funeral during medical school for their auntie, well, according to our guidelines at the medical school, well, that doesn't count. You don't get an excuse for an aunt. If it's your mom, yes, but not your aunt. So we have built-in cultural incompetence just in terms of even how we define families. And we've seen a lot of disruption in our families as a result. Just real quick on the disparities. I mentioned the terrible numbers for men from Pine Ridge. In North Dakota, statewide, the average age of death is 77.4 years for the white population in North Dakota, and you can see 56.6 years for American Indians in North Dakota. So in many ways, this is third world health conditions. And I like to remind my colleagues in public health academics, we do not have to cross an ocean to find third world health conditions. It's right here. Let's stop ignoring it and let's take it on. Let's lean into this and do something about it. Our disparities in chronic disease, of course, much higher with diabetes and many parts of the country cancer, but higher rates of alcohol-related deaths, accidents, suicides. What's tragic about our suicide rates in the Dakotas, it's more than double for American Indians, but it happens at a much younger age. We see a spike of suicide in the teen years and early adulthood. So not only is the rate twice as high, the years of potential life lost are even worse because of early suicide. So why is all of this happening? One of the studies that I participated in, I was a co-principal investigator for what was called the South Dakota Health Survey. And in this study, we basically cut and pasted from other surveys validated questions. So a lot of Burfus questions. We also screened for mental health conditions, so not self-report, but actual screening. So PHQ-2 for depression, GAD-2 for generalized anxiety disorder, Audit-C for alcohol use disorder, and we included the ACE study as well. So the outcomes were really tremendous. When we look at the outcomes for mental health screening, each grouping of bars, the far right light blue bars are reservation populations. And for depression, anxiety, and post-traumatic stress, significantly higher levels of positive screening for the mental health conditions for the reservation-based populations. Then when we look at our ACE scores, significantly worse adverse childhood experience scores for the American Indian population in South Dakota as compared to the rest of the state. We had some people who responded to the survey who had ACE scores of 10, meaning they had experienced every one of the defined adverse childhood experiences. Not surprisingly, each of the individual scores was significantly higher, measures of abuse, neglect, and household dysfunction. So I didn't want to be too data heavy, but just know that our preliminary data from many states shows that the adverse childhood experiences scores are much higher for American Indians. And not surprisingly, we have some terrible health outcomes. So we have a lot of challenges ahead of us. Poverty, unresolved trauma, ongoing marginalization, and really in many ways inattention and neglect of our issues. And the not surprising outcomes with disparities in health, education, income, and worsening inequity and suffering and death. So we need to address equity in a much more comprehensive way. We can't think of this in our silos of medicine, silos of public health, silos of behavioral health. and even social services. We have to look at it more comprehensively. So I'm sure many of you have seen this image or something similar in the past. I like this way of envisioning the difference between equality and equity. And equality, it's a one size fits all, right? Broad brushstrokes. Everyone gets the exact same Medicaid plan, for example. Assuming that one package of services will meet the needs of every individual and each diverse population. So on the left, that's equality. Everyone gets the same services whether you need it or not. The guy on the left didn't need it. It's serving the guy in the middle okay, but the one on the right is still underserved. So the idea of equity is to raise everyone's health status to an equivalent level, on par with each other. So we're not just looking at the package of services, but what are the actual needs of the individuals and the communities. So I'd shown this image for years, and a couple of years ago, someone sent me a slide that I think is just brilliant. And the question is, why is that fence there in the first place, right? So rather than just think about the package of services to overcome the fence, let's knock down the fence, right? What are the systemic barriers leading to health inequity? And how can we be interdisciplinary and intelligent enough to knock those things down? And I'd put forth that's really the role of academic public health, to work collaboratively across multiple disciplines and address things. We need those packages of services. You know, we need to think in terms of equity, but we also have to look at systemic barriers and what can we do collectively to get rid of those barriers. In terms of next steps, and just in the last couple minutes, I do have some good news. I always hate to be the bearer of just nothing but bad news, you know, so at UND, we are starting a new Indigenous Health MPH program this fall, available 100% online. So if you want to master public health in Indigenous health, that's what we have available through UND. And then starting next fall of 2020, a PhD in Indigenous health, the only one like it in the world. And it's really a shame it's taken this long to do this. When I think about the impact of colonization worldwide, we see the same pattern of health disparities, whether you're American Indian, Alaska Native, First Nations in Canada, Maori in New Zealand, Pacific Islander, Aboriginal Australian. We see the same patterns of outcomes based on colonization. There's an entire arena of health policy, health programming, and socially and culturally acceptable ways to address this. So we're planning to do that. So just very briefly, the coursework will include principles of Indigenous health, identifying the Indigenous populations worldwide, and they are everywhere. Applied biostatistics and epidemiology using data sets that include Indigenous data. So it's not just theoretical, but how do we actually look at the data for Indigenous peoples? It is methods heavy, but we need our own researchers leading these efforts. So quantitative, qualitative, mixed methods, community-based participatory research frameworks, as well as tribally driven frameworks. And as Indigenous peoples, we've been doing research for thousands of years. We just had different terminology for it. So Indigenous research methods is a part of this. In terms of program evaluation, we also have a health policy courses. Then for program evaluation, we need to build our evidence base of Indigenous specific programs. So we need to evaluate programs, but do it in a culturally appropriate way. So in evaluation of public health programs, but also Indigenous evaluation frameworks. And then finally, Indigenous leadership frameworks. So for those who might be interested or know students who want a deeper dive into Indigenous health, we're starting that at UND. In Lakota, we have a lot of values that we look at as being very important, and one of them is fortitude. And in fortitude, we don't have a word that translates directly into that, but we have a couple of ways that we say it. One is itate anaji, which means to stand in the wind, to face the wind, to face the challenge. And we learn this from our animal brothers and sisters. And when you see in the plains, when there's blizzards and you have a herd of buffalo, it's the bulls are standing facing the wind, protecting everybody, you know. And that's what we need. We need to be courageous enough to face the challenge, to face the truth, even when it makes us uncomfortable, even when it's unpleasant. But that's the only way we will get toward equity. And then thinking about the health of children, I always like to end with this saying from our sister tribe, the Blackfeet. A child is sacred, and when that child comes into the home, the family must welcome it. And if the child is happy and feels the want, he will come into this world very, very strong. And not to know this is to know nothing. And not to know this is to know nothing. We have to treat our children as the sacred beings that they really are. But we need the positive frameworks. We need the positive community environments, the social and ecological environments in which to live in a healthy way again. And I also have selfish reasons for this. I actually have 4 children. Here's a picture of 2 of them. What if in the time of their grandchildren, we don't have to have this discussion anymore? Wouldn't that be a beautiful vision for all of us to consider? Thank you all very much for your attention. Yeah, so if there's any questions or comments, yeah.
Thank you very much for that eloquent and moving presentation. You talked about federally recognized tribes at one point. The Duwamish and other tribes here are not federally recognized. What's the advantage to a tribe to be so recognized?
Yeah, it's a great question. So there's a lot of tribes in the U.S. and really throughout North America, and some of the tribes have what's called federal recognition, where the federal government recognizes them as a tribe. And the advantage to that is then access to programs through Indian Health Service, through Bureau of Indian Affairs, and other related programming. There's even scholarships, for example, that are linked to being an enrolled member of a federally recognized tribe. But you're right, we have a lot of state-recognized tribes that are not federally recognized, and they don't have access to some of those same services. Here's one of the challenges, though, because agencies like IHS are terribly underfunded. So if you are one of the 573 federally recognized tribes, are you incentivized to letting more tribes be recognized? Now, from an altruistic perspective, sure, but it doesn't mean that our budget's going to go up. So the more tribes that get recognized, the less resources per tribe if the budget doesn't increase. So the best way to divide and conquer is to limit resources, and it's still happening today because of exactly those issues. Yeah. Here's this.
So we're talking about earlier you were talking about how there's not that much representation from indigenous or native communities in the U.S. in our legislative areas.
Right.
Now, you've probably been to a lot of them. What is the main resistance to you? Is it really that people just don't give a shit, or are they really like, it's not in the front of their head, like, with knowing all of these disparities?
I think there's multiple factors at play. One, just to acknowledge, in this last election, I'm sure many of you know, the very first American Indian women were elected to Congress. There were 2 of them. Let's give them a hand. Yeah, Deb Haaland from New Mexico and Sharice Davids from Kansas, both American Indian women elected to Congress. But isn't that remarkable? It took until 2018 for an American Indian woman to actually get elected to Congress. So I see hope for the future with some of those outcomes. But if you are a legislator from a place where there are no tribes, you have no motivation to vote for more funding for Indian Health Service, for example, because it's not going to benefit any of your constituents. So if we look at representative government, the challenge with that is when you have a very small minority population, we are the minority of the minority populations. We are not well represented, and even in other parts of the country that are represented appropriately in Congress, they don't have us in their constituency. So there's that piece of it, just the logistics and dynamics of representation. The other piece of it, quite honestly, there are representatives from states that have tribes that are still not supportive. And it's really unfortunate. We just happen to have several states that are ultra-conservative, that don't want to vote for more funding for healthcare, and that's where a lot of the tribes are. If you look at Oklahoma, North Dakota, South Dakota, Montana, even Arizona and New Mexico are changing a little bit, but we just happen to have concentrations of population in states that, quite frankly, don't care about our outcomes on the balance. I've worked with South Dakota legislators, and we're advocating for different types of programs to integrate with the state. And one of the legislators, this is about 10 years ago now, he actually said to me, well, why is there an Indian health service? There's not a Norwegian health service. Just no understanding of history and the trust responsibility that the US government has, and no understanding of treaties. And this is a lawmaker in South Dakota, So not only is there a challenge with lack of understanding of the truth, there's actually, I think, in many ways, semi-intentional ignorance on behalf of some of our elected officials. So we have a huge challenge politically. So what that tells us as American Indians, Alaska Indians, we can't solve this alone. We need collaborators. We need partners in advocacy. So we need all of you. We need people who are American Indian and non-Indian to actually work with us collaboratively to fix some of these policy challenges that are leading to ongoing inequity. So I guess that's a very long answer, but for some people, it's that they don't understand it, don't care, or purposefully vote against our needs.
I work at Chief Seattle Club here in Seattle, where we serve Native people experiencing homelessness. And we've worked really hard in the past, but especially the last couple months, on the point-in-time count, the homeless census, so to speak, on getting them to include Native people experiencing homelessness, or Native people in general. And there's been a lot of backlash on that, and there's been a lot of resistance to include Native people and just people of color in general. So, clearly we can all see from an outside perspective how racist data systems affect public health, but is there just sort of your Native public health perspective? Do you have any public health wisdom on how those things correlate to each other? Racist data systems and public health?
Yeah, so the data systems are very challenging, and how do we define the population? So for example, census is self-reported. IHS data is just for users of IHS. So I'm American Indian, but I don't use IHS because I have insurance. So I'm not in that data set, Then there's also tribally enrolled data sets. So I'm an enrolled tribal member, and I'm also self-identified in the census, but I'm not in the IHS data. So how we look at the data is very challenging. And that's part of why we need applied biostatistics and applied epidemiology for Indigenous populations, because our participation in those data sets varies significantly. BRFIS is a wonderful survey tool, the Behavioral Risk Factor Surveillance System, but American Indian participation is incredibly low. So we can't use BRFIS data and assume that we're actually answering questions about American Indians. So we haven't found the right solution, but we do have tribal epidemiology centers and urban Indian epidemiology centers that are trying to address this. And Abigail Echohawk in the back runs one of those right here in Seattle, so yeah. But
Okay.
thanks for that question. And then one last question.
Yeah, one last question.
Thanks so much for being here. I was wondering if you would be willing to share kind of the time and the effort it took for you to for there to be creation of the MPH and the PhD programs that focus on Indigenous health, and what kind of support did you need from peers, students, faculty, institution, policy level, and what kind of challenges did you experience?
Okay, so to develop the programs, the time frame. So I've been thinking about this for a long time because I used to be the executive director of the Great Plains Tribal Chairman's Health Board. And in truth, I was really disappointed with the lack of knowledge of MPH graduates about Indigenous health or American Indian health. And I was very fortunate. I went to Harvard to get my MPH, and I was impressed with how much my professors, they could talk about Southeast Asia, they could talk about Sub-Saharan Africa. They knew nothing about what was going on in Indian country. And I think that's a pervasive problem across public health academics, is lack of understanding of Indian health. So I'd been thinking about this for years. And when I was asked to apply for the directorship of the MPH program at North Dakota State University, this is now 8 years ago, it was with the caveat that I'll do this, but I want to start an American Indian public health program. So I did have support to do that. And then now at UND for the doctorate, it just happens to be at a time frame when they're wanting to expand doctorate opportunities and MD, PhD, dual degree opportunities. So I've been very fortunate to find support to move in that direction, but I haven't found that support in every public health arena. I think there are just certain pockets that recognize that this is a need. And I would say this university, this College of Public Health here, does recognize the need to move in this direction. So in my own experience, it really depends on where you're located, but if you have the right leadership, these things can move forward, and they are moving forward at UND. All right.
All righty. Thank you. Please join me in thanking Don again for an amazing presentation. And please join us downstairs in the lobby for a reception, and feel free to come up and chat more.